So I'm going to talk about clinical management of channelopathies. In the interest of time, I'm not going to talk in detail about all the various channelopathies, but I'm going to limit my discussion to these four listed here. First, some basic things about terminology. When we talk about genetic arrhythmia syndromes, we include those that cause primary electrical problems such as Brugada, long QT, short QT, and CPVT. In addition to these syndromes that cause polymorphic VT and sudden cardiac death, there are others that cause familial sinus node dysfunction, heart block, AFib, and WPW. In a different category are those that predominantly affect the myocardium, such as hypertrophic cardiomyopathy, ARVC, and some forms of dilated cardiomyopathy. But these, in addition, can have arrhythmias associated with them. The term ion channelopathies is used for some of these genetic arrhythmia syndromes that cause primary electrical problems because many of these are associated with ion channel mutations. So first, the congenital long QT syndrome. So this is a genetically inherited syndrome, occurs in two flavors, the autosomal dominant Romano-Ward syndrome and the autosomal recessive Jervell-Lange-Nielsen syndrome, which is associated with deafness. The ECG manifestation of this, as we all know, is a prolongation of the QT interval. In addition to this, there are other abnormalities such as T-wave alternance, T-wave notching, and inappropriate bradycardia. The risk with this is Torsades-Dupont, which can cause syncope or sudden cardiac death. Example is shown here, where torsade is initiated by a short-long-short sequence that then results in polymorphic VT. So we'll consider the diagnosis, risk stratification, and management of this syndrome. So when we talk about diagnosis, let's consider two different scenarios. On one hand, we have a patient, a 48-year-old female, known on heart disease who presents with syncope, probably taking amitriptyline and Phenergan, and her presenting ECG shows a QT interval of 480 milliseconds, which we can all say is prolonged. Does she have long QT syndrome? A different patient, an 18-year-old who had to be pulled out of the swimming pool because she was noted to be drowning. Her sister died suddenly while jogging, and her uncle died in his 40s. And she has a normal appearing ECG with a QT interval that seems to be normal. Does she have long QT syndrome? So to answer these questions, we first have to know what is a prolonged QT interval. As you know, the limits of normal QT interval vary with age and gender, and the normal values are shown here. A general rule of thumb is when the QT interval is less than 440, it is probably normal. More than 480, probably prolonged. And between 440 to 480, it depends. The normal value of QT interval also varies with the heart rate. There are various correction formulas that are used that are shown here. Most common one that we use clinically is the Bezet's correction. We also have to know how to calculate the QT interval appropriately. In a complex like this, it's very easy. When you have a U wave that occurs after the T wave reaches the baseline, the U wave is typically not included in the calculation. If you have a bifid T wave, both the humps are included in the calculation of the QT interval. Most confusion arises in situations like this, where you have a small U wave that starts before the T wave reaches the baseline. And in situations like this, the consensus is to use the tangent method, where you draw a tangent at this maximum slope and calculate the QT interval where this reaches the baseline. We also have to exclude many other acquired causes that can prolong the QT interval, including drugs, both antiarrhythmics and non-cardiovascular drugs, and many electrolytes and other metabolic conditions. Another factor to take into account, there is an overlap between the QT interval of normal population and the QT interval of people with congenital long QT syndrome. When the QT interval is very prolonged, more than 480 or so, it almost always is due to congenital long QT syndrome. But notice that some people with this syndrome will have a QT interval that is considered to be normal. So how then will we be able to come to an accurate diagnosis? One way is to use a scoring system like the Schwartz score that was available starting from the 1990s. This scoring system uses not just the QT interval, but other ECG findings, clinical history, and family history to come to a score. And when the score is more than 3.5, you're very likely to have long QT syndrome. There are other ways to increase your sensitivity of diagnosing long QT syndrome, especially when you suspect this and the QT interval appears to be normal. Epinephrine has been used, infusion has been used to bring out latent long QT interval in long QT1 patients. This is not done so commonly nowadays because in borderline cases, we now resort mostly to genetic testing. This is an example with epinephrine infusion where the QT interval is normal at baseline, and after epinephrine infusion, QT interval is prolonged. When we talk about genetic testing, there are many genes that are associated with long QT syndrome, and the list continues to grow day by day. The most common genes that are involved are these three that cause long QT1, long QT2, and long QT3. Long QT1 and 2 are due to loss of function mutations of IKS and IKR alpha subunits respectively, whereas long QT3 is due to a gain of mutation of the sodium channel gene. These three account for most of the clinical cases of long QT syndrome, and genetic testing in this day identifies more than about 75% of cases of long QT syndrome. So with this background, how do we make a diagnosis of long QT syndrome? If the QT interval is prolonged more than 480 milliseconds, certainly if it is more than 500 milliseconds in the absence of any other condition, you can make a diagnosis. If the Schwartz score is more than 3.5, you can come to a diagnosis. Or thirdly, in borderline cases, if you do genetic testing and find an unequivocally pathogenic mutation in one of these genes, you can make a diagnosis. So moving on to risk stratification. First, a word about genotype-phenotype correlation. The three major long QTS subtypes are associated with characteristic ECG abnormalities. Long QT1 has the T waves that are high amplitude like this. Long QT2 has broad-based and bifid T waves, whereas long QT3, the T wave is normal and it's only the ST segment that is prolonged. With respect to the triggers associated with each of these types, long QT1 is episodes are typically associated with swimming and exercise, whereas in long QT2, it's auditory and emotional stimuli that trigger these episodes. Long QT3, on the other hand, the episodes typically occur during sleeping and rest. The association of these triggers with episodes is even stronger when you consider lethal cardiac events. This is in general triggers and episodes. This is with lethal cardiac events. But notice that this is not absolute in the sense that a long QT1 patient can have episodes triggered at rest, and a long QT3 patient can have episodes with exercise. When we consider risk stratification, we have to consider the QT interval, syncope, age and gender, and genotype. Of all of these factors, the most important is the absolute value of the QT interval. The more prolonged the QT interval, the higher the risk. Registry data have shown that when we consider age and gender, early on, males seem to have a higher risk, but as the age increases, females have a higher risk than males. Genotype can also help with risk stratification. Even after established diagnosis of long QT syndrome, once we find out what the exact genetic abnormality is, that can further help risk stratification. So with this, we can come up with a risk stratification score or risk stratification subgroup The highest risk of these are patients with long QT syndrome that already have had cardiac arrest or episodes of torsade. In the lowest risk group are people that have long QT syndrome, but the QT interval is less than 500, and if these people have not had any syncope in the last 2 years. People with a QT interval more than 500 or a recent syncope would be what we consider moderate risk. Several other risk stratification scores are being developed, and I'm sure we'll see more modifications in years to come. So how do we manage these patients? There are some general measures and some measures that are specific to long QT syndrome. Avoidance of competitive sports is important because sympathetic stimulation brings out triggers in many of these patients. The specific stimuli that trigger each of these subtypes have to be recognized and avoided. QT prolonging drugs have to be avoided like in any patient with long QT, whether it's congenital or acquired. But in addition to the QT prolonging drugs, stimulants have also to be avoided in congenital long QT patients because they can trigger episodes. Of course, potassium, magnesium, and other electrolytes have to be repleted to normal. The specific measures for people with long QT syndrome include treatment with beta blockers predominantly, placement of devices if needed, mostly ICDs, and rarely sympathetic ganglionectomy. Sympathetic ganglionectomy is mainly used as a bridge to devices in very young patients, or sometimes in patients who have multiple ICD shocks even after treatment with beta blockers. All patients with long QT syndrome should be considered for treatment with beta blockers. Though the benefit is most in patients with long QT1, there is also some benefit in other subtypes, and no subtype should be denied beta blocker just because they have a different genotype. And the beta blockers that have been shown to be most useful are the non-selective beta blockers such as propranolol and nadolol. And it's important that once a patient is put on a beta blocker that they stay on it, because stopping a beta blocker after once having been on it increases the risk of having episodes. For patients with long QT3, there is some data with using sodium channel blocking drugs such as mexiletine. So who should get an ICD among these patients? Of course, patients who have had cardiac arrest clearly would benefit from an ICD. Patients having recurrent syncope after treatment with beta blocker would also be straightforward candidates for ICD. In addition, decisions should be individualized to identify specific high-risk patients who might benefit from ICD placement after treatment with beta blockers. These may include patients with a very prolonged QT interval, patients with the JLN subtype of long QT syndrome, and so on. In centers such as ours, we have had a long experience of treating patients with long QT syndrome with a combination of physiologic pacing in the AIA mode along with beta blockade. Beta blockade serves to counter the sympathetic stimulation that causes triggers, whereas pacing at a high rate decreases the risk of having torsade, and torsade risk, whether it is congenital or acquired long QT, is higher at low heart rates. So that is why you tackle both these risks with this method. Because there have been case reports of patients with pacemakers who have cardiac arrest, this is currently not recommended, but I think this is still open to debate. So moving on to Brugada syndrome. So Brugada syndrome is also a genetically inherited syndrome. The characteristic ECG abnormality here is incomplete right bundle branch block with ST segment elevation in the right precordial leads, V1 to V3. The characteristic arrhythmia is polymorphic VT and VF that causes syncope or sudden cardiac death. And consider here a young male who presents with presumed orthostatic syncope. He's on no home medicines, and this is what his ECG is. And the question is, does this patient have Brugada syndrome? The diagnosis is mainly based on the ECG. And there are 3 Brugada patterns that are described with respect to this. Type 1 Brugada pattern is characterized by ST segment elevation of at least 2 millimeters in at least one of these 3 leads, associated with a curved pattern of ST segment elevation, which is characterized by negative T waves. Type 2 and type 3 Brugada patterns also have an ST segment elevation of more than 2 millimeters, but they are characterized by an upright T wave resulting in a saddleback pattern. Important thing to keep in mind here is that it is only the type 1 that is diagnostic of Brugada syndrome. Type 2 or type 3 Brugada patterns should make you suspicious, and you might do additional investigation to see if you can bring out a type 1 pattern in these patients. Just like with long QT syndrome, there are many other acquired conditions that can result in Brugada patterns on the ECG, and these have to be excluded. If you see somebody with a type 2 or type 3 pattern, there are things that you can do to see if you can bring out a type 1 pattern in these patients. The most useful and least invasive is to just change the ECG lead placement. By placing the V1 and V2 in third or second intercostal space, you might convert a type 2 or 3 pattern into a type 1 pattern and thereby make the diagnosis. Sometimes you can also use sodium channel blocking drugs to see if you can convert a type 2 or 3 to type 1. And when sodium channel blocking drugs are used, this has to be done in a controlled setting in the EP lab and not in a clinic setting. Because not only may patients convert to type 1 pattern, that might also trigger episodes in these patients. What makes the diagnosis even more challenging is that the ECG changes are often fleeting, and transient normalization of ECG can occur spontaneously in these patients. Therefore, when you suspect Brugada and you haven't seen a type 1 pattern, it's important to do serial ECGs and to have the patient get ECGs whenever you suspect they may have this ECG abnormality more likely. That is, when they have febrile episodes, for example, fever is known to bring out the ECG abnormality, and patients should be advised to get ECGs when they have fever. This is an example of a patient who has a baseline type 2 or 3 Brugada pattern that is converted to type 1 pattern by using a sodium channel blocker, procainamide. And next, by using quinidine, which we'll talk about in a second, the pattern is again reverted back to a type 2 or type 3 pattern. So the way you make a diagnosis of Brugada syndrome is by looking for a type 1 Brugada ECG morphology, which is greater than 2 millimeter of ST elevation in V1 or V2, either spontaneously or with lead placement or with sodium channel blocking drug. Genetic testing is not part of the diagnostic criteria, because genetic testing is positive only in about 20% of these patients. But if genetic testing is done, typically the most common abnormality seen is in the sodium channel gene, where there's a gain of function mutation. Long QT syndrome, it's a loss of it's a loss of function of sodium channel mutation here. In long QT syndrome, a gain of function of sodium channel causes the prolonged QT, whereas a loss of function of sodium channel gene results in Brugada syndrome. A scoring system similar to the long QT syndrome has also been proposed for Brugada, but it is not yet used clinically very often. The main problem that is seen with Brugada syndrome is unopposed activity of the ITO channel and ITO current with the sodium channel mutation. Normally, the ITO is responsible for this repolarization notch, and the sodium channel, the late sodium current, tends to oppose this. When you have a sodium channel mutation, you have unopposed activity of this ITO current. And even though the sodium channels are ubiquitously distributed, ITO is regionally distributed in differential fashion. This is what is responsible for the regional variation of the ECG morphology in Brugada syndrome, why it is most likely seen in the right precordial leads. I won't go over the mechanism of arrhythmias in Brugada syndrome in the interest of time, but moving on to the triggers, we've already talked about fever as being an important trigger, both to bring out the ECG abnormality and to bring out episodes. Vagal stimulation, large meals are also important triggers. Importantly, these episodes are diminished by adrenergic stimulation. They're also diminished by isoproterenol and with quinidine. With isoproterenol, with quinidine, the reason for for the decrease in episodes with quinidine is that quinidine is an ITO blocker. So it counteracts that unopposed activity of ITO that is seen in this syndrome. The mainstay of treatment for patients with Brugada syndrome is an ICD in high-risk patients. Who gets an ICD? If somebody already has episodes of cardiac arrest or syncope with Brugada syndrome, that's a clear indication for ICD. Patients who are not candidates for ICD or who refuse ICD may be considered for treatment with quinidine. There is also some data about doing catheter ablation in the epicardial right ventricular outflow tract to normalize the ECG and decrease episodes in some patients with Brugada syndrome. When patients with Brugada syndrome present with VF storm, the treatment of choice would be isoproterenol. That is counterintuitive. Most of the times we use isoproterenol to bring out arrhythmias, whereas in patients with VF storm with Brugada, isoproterenol is used to actually decrease the episodes. I will skip through the risk stratification of Brugada, but just mention one word here, which is the role of EP study in patients with asymptomatic Brugada syndrome. Patients who are noted to have a type 1 Brugada pattern and therefore have a diagnosis of Brugada syndrome and have no symptoms may be considered for an EP study to see if you have inducible VT and VF. Whether non-inducibility is really useful in saying they're very low risk is a matter of debate. So I'll leave it at that just to make the point that this is sometimes considered, but more and more centers are not using EP study for risk stratification in patients with asymptomatic Brugada syndrome. Do you have a few minutes or? Okay, so I think in the interest of time, we'll probably start. I don't have time to go through the congenital short QT or the CPVT, but I'll probably leave that up for questions and answers to it. Thank you.
This excellent talk is open for questions. While we're waiting, any comments in terms of screening of affected family members and how you coordinate things with genetic counseling and other things once you make the diagnosis?
Certainly. So nowadays, it's even after making a clinical diagnosis of any of these channelopathies, whether it is long QT, Brugada, short QT, or CPVT, it's important to consider genetic testing in all these patients. Why? One, it's useful for risk stratification in some of these, such as long QT syndrome. Second, it helps the diagnosis in borderline cases, especially in patients such as with long QT, borderline long QT, or CPVT, where genetic testing is likely to be positive. Thirdly, and most importantly, it is helpful for family members. Rather than do serial ECGs over and over again in a family, if you identify a mutation in the affected proband and you test for the same mutation in the family and they are negative for that, their risk goes back to the same as the general population, and you don't need to keep doing serial screening in these patients. Of course, if the mutation is positive, then you are committed to keep doing serial ECGs. The same applies, for example, to hypertrophic cardiomyopathy. Rather than do serial echoes, do a genetic testing. If it is negative, risk is same as the general population.